So these are my disclosures. So we're going to talk about evaluation of dyspnea in people who have sarcoidosis, and then we're going to talk about the right ventricle and sarcoidosis, since this is a right ventricular symposium. So I'm going to start, I'm basically going to do this by presenting you guys a case. So this guy is a 58-year-old male who's referred for a question of pulmonary hypertension associated with sarcoidosis. And this was all started after he had a presumed gout flare, but his ankle remained swollen, and we'll get to it. He was eventually diagnosed with sarcoidosis. This goes on, and he gets short of breath with moderate exertion, clearly doing less than he was doing 6 months ago, and has new lower extremity edema. Okay, and during his initial cardiac evaluation, he's found to have a new right bundle branch block. Okay, can I ask people, have people there? Okay, I love it. All right, so what are you thinking? What do you want to do?
You know, I generally, what I do is I move forward with sort of what are the potential things that could be causing PH at the same time as confirming the diagnosis of PH. So right heart cath, CAT scan, rheumatological workup.
All right,
All at the same
you want to
time.
get an echo first?
I did, but you told me to move on.
All right, we can do that. All right, so he gets seen. His vital signs are really, his blood pressure's low, but he's not orthostatic. His heart rate's 87. His stats are good, and his BMI is about 28. That doesn't change anything you're going to do, right? Okay. On his exam, completely non-helpful. He's got flat JVP. His lungs are clear. He maybe has a P2 because you're thinking down that road. So your stethoscope, you pull out the one with the built-in P2, right? Okay. No edema and nothing else. All right. So still, okay. So he gets labs, nothing. He's got normal immunoglobulins, LFTs, lymphocytes. His SPEP's normal, but his EKG does in fact show a new right bundle. Okay. And his PFTs are there. He does have evidence of restrictive disease, but his DL is okay. All right. He gets an echo. All his chambers are normal. His LVEF's 58%. He's got no wall motion abnormalities, got no significant vascular disease, and insufficient TR jet to estimate his PASP. Change what you want to do?
I mean, looking back, you mentioned something about question pulmonary hypertension. So where did that question come from?
From the person who referred him in.
So it doesn't actually change them that much.
Actually, because it was brought up because of the new edema and the new right bundle on his EKG.
I mean, one could start asking the question of why the person has a new right bundle branch block first, without jumping to satisfying that person's curiosity about the pulmonary hypertension. So then potentially another type of cardiac imaging that would reveal something would also be the way to go.
All right.
I gotta hand this to someone.
So he gets a CT, which shows bulky, symmetric, mediastinal, and hilar adenopathy going along with what we think. At this point, he doesn't have it. I led you in. He doesn't have a diagnosis at this point, okay? But they think he has sarcoid. So he has no noticeable parenchymal findings. He has no axillary lymphadenopathy, but he does also have abdominal lymphadenopathy. He gets bronched. A biopsy shows non-necrotizing caseated granulomas. All the cultures are negative, etc. So now you have the definitive diagnosis of sarcoid. All right. So where do you want to go now? You want out of here, so.
Does anyone support this? I mean, I think someone has, the right bundle branch block doesn't explain the edema. Someone was
maybe
thinking,
it does.
I mean, maybe, but it doesn't. It's not a slam dunk.
Okay.
So, if I think you could still make the case that you need to because we haven't exonerated pH. We've just not had sufficient evidence of it.
Okay.
So you could think about exercise testing to see if there's something early, or you could think about right heart cath right off the bat.
Okay.
You know.
All right.
I mean, I like.
So he
right
gets a
heart
cath. All right. And interestingly, his filling pressures are normal. His mean PA is 20. Okay. His PA sat's 59. His cardiac index is 1.56. So now what are you thinking?
I'm thinking where's the PVR?
Well, let's see. I can tell you his PVR is just, borderline because his cardiac index, his cardiac output's so low.
Yeah, now I'm calling cards.
Huh?
Now I'm calling our cardiology consultants.
All right. Who's a cardiologist here? Nobody will own up. Oh, Jane's a cardiologist. Well, Paul is. So we have to pick on either Paul or Jane.
Where's the MR?
You want a cardiac MRI? Good man. So these cardiologists are good for something, right? So he gets a cardiac MR, okay, which shows a normal left ventricle, size, function, and wall thickness. His LVEF is 55%. He's got top normal RV size with an RVEF of 33%, okay? He's got IVS flattening and paradoxical motion, as well as questionable mild focal delayed enhancement, suggestive of elevated right ventricular pressures, which he didn't have on his cath. No evidence of cardiac sarcoid. Okay, Paul, now what do you want to do? Go start a company. No.
I like that.
Huh?
Pet.
Pet?
Yeah.
Okay, so Jane goes for a pet. All right. I'm going to try and see if I can make this work. At least it lights up there, okay? So the PET scans read as significant uptake in both the left and right ventricular myocardium involving the basal inferior walls, et cetera, and consistent with cardiac sarcoid. And he also had some uptake in mediastinal nodes and stuff like that. So it turns out that this guy has cardiac sarcoid, even though the CMR showed nothing. Okay? So, Paul, how do you explain the discrepancy between the two?
Actually, we see this, and we just. I was telling Ava, who was a fan of the PET too. I don't even know how we prioritize which scan, but I think there's such a preclinical suspicion based on the the CT radiography. I don't know. Who wants to chime in?
This is one of those scenarios where the patient then comes to the cath lab and gets an RV biopsy for tissue diagnosis.
Okay. Do you think is the PET scan enough? Or would you biopsy him?
I think with the discrepancy between the cardiac MR and the PET scan, and Paul's absolutely right. We see this a lot, where there's a discrepancy between the two tests. But when there's some question of whether or not this is, if this is not enough to explain everything, then that's where the biopsy comes in.
Okay. So nowadays, if you think somebody has cardiac sarcoid, do you go to PET scan first? Do you go to MR first?
If we really have a high index of suspicion, then we'll just go to PET scan first.
Okay. Good. Well, he didn't get biopsy because we were convinced that the uptake was such and the inflammation was such with the sarcoid that this was probably what he had, right? So he gets treated. So he's got cardiac sarcoid with RV dysfunction, which actually I'm going to talk about at the end. He got treated with prednisone, methotrexate, et cetera, and he got genetically tested for ARVC, and he had an ICD implanted. Okay, I'm going to come back to the ARVC, and 4 months later, his PET scan is completely back to normal. His RV is completely normal. All the metabolic activity is gone. He feels dramatically better. Okay, and there's no evidence to suggest active sarcoid. He's got normal perfusion, et cetera. The steroids are weaned off. The methotrexate's continued. And 7 months later, his surveillance PET is really completely normal. Okay? And there's no evidence of sarcoid except in his mediastinal nodes and stuff. You like that?
I do, but you didn't tell us anything about his genetic testing for ARVC.
So his genetic testing was negative. Okay, for those of you who don't know, there are forms of asynchronous ARVC or ARVD, whichever you want to call it, that is genetically, but those are usually younger people.
Younger people with desmosomal mutations.
So although he didn't fit, we did get him tested and it was negative. So, and interestingly, if you look in the literature, there are cases of ARVC/ARVD that basically are impersonated by cardiac sarcoid. There's several cases of this, and so this guy is one of these. And he's now, last time I saw him, he's probably about a year out, feels dramatically better. He's still just on methotrexate, and has no evidence of cardiac involvement with a sarcoid anymore. Well, it's there, but it's clearly not active. Okay? So the key point is, in sarcoid patients with dyspnea, consider cardiac sarcoid, and the edema and the new right bundle were probably related to the cardiac sarcoid and not pulmonary hypertension, which of course I immediately thought of too, and that a cardiac PET might be more sensitive than a cardiac MR in diagnosing, we'll say, active cardiac sarcoid or inflammatory cardiac sarcoid. And as Jane pointed out, if you really are suspicious, actually it may be the first test you want to do rather than cardiac MR. Okay, thanks. Huh? Okay, where am I not going?
So we now have about 10 minutes to discuss this case. So if anybody has any questions for Dr. Farber.
Oh, okay.
Nothing. Well, let me start out by asking, when his cardiac sarcoid improved on his PET scan, what about his extracardiac sarcoid? And were there improvements there? And
the abdominal lymphadenopathy did improve and go away, but the hilar and mediastinal adenopathy, I mean, I suppose I could say it looked better, but it really was pretty much still there.
so, Paul?
You hadn't had that peripheral biopsy that was positive. Would you have insisted on an RV biopsy before treating?
That's a good point. That's different. We didn't, I think you're probably right. If we did not have a definitive biopsy from his bronch,
Yeah.
we probably would have biopsied him. Now, wait, so don't go away yet, Paul. So how often, no, my question was, so how often, since it's the... That's unusual. So how often, if you do biopsies, since it is patchy and it is inflammatory, do you get false positive, false positive, or false negative? Mostly false negative.
Yeah. It's pretty high. Say it's
Yeah,
like
that's the
50%,
problem.
right?
It's,
Yes, but you have a scan that localizes
So
it
you
to
can
a
go-
territory, so you do an echo-guided RV
yeah, you
biopsy.
could. No, I'm certainly not going there.
Oh, no.
Okay.
So we have gone there.
So
Two
actually,
questions.
my other question to the biopsy people before we go. So in somebody who has active inflammation in their heart, like this, is there a higher risk of a cardiac biopsy of doing something horrible than somebody who doesn't?
Well, I would say, I mean, do you want to answer that? Or I'm happy to. For us, if you do it with echo guidance and you stay away from the free wall, then yes, you're okay. What's your practice, David?
Same, yeah. We've done it more and more for myocarditis, rarely, but we do it sometimes. And then for the ILI, the checkpoint inhibitors for melanoma treatment, myocarditis, we do a lot of them, and we sometimes do the LV biopsies when there's a reason not to do the RV. And with echo guidance, it's been okay, but everybody's blood pressure is really high for the duration of it, so if we can avoid it, we avoid it.
Okay, so as long as you use echo guided,
Yep. And that's how we do all native heart biopsies.
okay.
So Dr. Richard had a question?
I have two questions. First one is on the ARVC. Wouldn't you have, are there in your research, or maybe Paul or somebody can answer this too, is there, the prototypical sort of fatty infiltration of the RV wall wouldn't you have seen that on MR, or is there some forms without fatty
It can be very-
infiltration?
It can be very subtle. You may not see it.
Oh, okay. I wasn't aware of that. The other question I had is, so say the hypothetical patient's not getting better or partially responding to your anti-inflammatories.
Those anti-inflammatories, you can up the game.
Yeah. So would you consider this as sort of like a situation where we see, like in a Fontan patient that has no pump capabilities, that you would still treat them with pulmonary vasodilators?
Whoa, that's a great question. Well, I mean, I don't know, because his PVR is normal, or right.
Well, that's what I'm saying, is normal might not be appropriate
him.
for somebody without a
Treat
pump,
him with
right?
pulmonary vasodilators.
I know I'm just kind of
No,
shooting out
listen,
the
it's a great question.
yeah.
I don't think it would be unreasonable to give it a shot. If you thought about it, just treat him for 3 months and see if he gets better. If he does, fine. If he doesn't, then, or if he gets worse, just back off.
Yeah.
Origin of this guy. The
I could-
national origin of the guy.
I couldn't hear.
What's his background, national origin?
Oh, he's a white guy from New Hampshire. Huh? He's just your average guy from New Hampshire.
Hi, I have a question about the ICD placement. Over here. Hi, I'm a cardiologist with Cambridge Health Alliance, and I have a similar patient which has active sarcoid, but he does not want to have an ICD. And what is the natural history of patients who have cardiac sarcoid who do not get an ICD? Is there risk of?
Well, I guess the worry in this guy was that he would, especially because he had a low EF and a low output, would that develop some sort of horrible ventricular arrhythmia that would take him out before you could actually treat him.
Okay. And
Everybody who was involved in the case thought that we weren't going any farther before somebody put an ICD in him.
And was the cardiac MRI truly normal? Because it did show some LG in some area of the left ventricular septum, right?
Did you have late gadolinium?
The cardiac MRI was not 100% normal.
Did you have late gadolinium enhancement in the movie?
Yeah, I mean, it's the only thing that it was amazing. The cardiac MR showed really nothing except the low EF of his right ventricle. No matter how so after the PET scan, we actually went back to the MR people and said, hey, look, this is the PET. And they still said, that there's no evidence of cardiac sarcoid on the MR.
Is the MRI as it's usually picking up scar, not so much active inflammation? Can you say that the PET CT was abnormal because there was inflammation, but not necessarily scar?
I don't know.
Thank you. Thank you.
So, but you guys have sort of confirmed now, if I think about it, I'd probably do a PET scan first.
So let me ask, did you ever do another right heart cath to see if his cardiac index improved?
No, not yet, but he's going to get one. We figured we'd wait, since he was better, we'd wait out to a year and then probably repeat it.
All right.
I,
Thank you very much.
thanks, guys.